Once pleural fluid has been identified, characterized, and quantified, the bedside sonographer is left with the question of whether thoracentesis should be performed. Thoracentesis is a safe procedure in the ICU, even in mechanically ventilated patients. As was seen in the introductory part of this course, the use of ultrasound to guide thoracentesis has been shown to result in a low rate of complications while making the procedure more efficient and safer. The benefits, indications, and advantages of ultrasound-guided thoracentesis have been thoroughly described throughout this course and will thus not be reviewed again in this section. We previously reviewed in details how to assess for the presence of pleural fluid through the detection of dynamic fluid signs and detection of anatomic boundaries of a pleural effusion. When using ultrasound for the purpose of guiding potential thoracentesis, the bedside sonographer should specifically aim at identification of pleural fluid and anatomic boundaries, identification of surrounding organs, namely the heart, liver, spleen, lungs, and aorta, and finally, demonstrate an unobstructed free access to fluid at a safe distance from surrounding organs. These simple and well-defined skills have been thoroughly reviewed in previous section of this course. Through strict adherences to these criteria, inadvertent organ puncture and the so-called dry tap should be virtually eliminated. For a particular patient, the clinician should assess the risk and benefits of a thoracentesis. Once the feasibility is assured, thoracentesis may be performed for diagnostic or therapeutic reasons. It is important to note that although we use the term ultrasound-guided thoracentesis, in the vast majority of cases, real-time ultrasound guidance for needle insertion is not used, so the needle insertion is not directly visualized by sonography. Let's review step by step how ultrasound should be used to assist in performing a safe and efficient thoracentesis. The patient must first be adequately positioned on his or her back or on his or her side, and the effusion must be thoroughly assessed. Pleural fluid must be recognized. Note that a physician proficient in the core objectives reviewed in this course will be able to not only drain large, free-flowing effusions, but also smaller ones. If fluid is detected, it can usually be accessed. An inability to detect dynamic fluid signs or the inability to localize a fluid collection within the pleural space boundaries does not imply the absence of important pathology or even the absence of fluid. The only possible interpretation of these findings in such instances is that sonographically guided drainage is not feasible. The interventional bedside sonographer should be concerned about the detection of fluid and its safe accessibility using findings with the highest possible specificity. Also, keep in mind that some small and/or loculated effusions would be better drained by CT scan as opposed to ultrasound guidance. By showing appropriate restraint in the interpretation of sonographic images, the interventional bedside sonographer should be able to eliminate problems arising from overdiagnosis and underdiagnosis. Once the effusion has been well assessed, one must determine the need and feasibility of safely doing the procedure. It's not because a large effusion is identified that it needs to be tapped or drained if there are no suspicion of an infectious process and if there is no respiratory compromise related to the effusion, such as shortness of breath, hypoxemia, or hypercapnia. This is analogous to finding a small collapsible inferior vena cava in a patient with no tachycardia, a normal urine output, and a normal blood pressure. The sole finding of a small inferior vena cava would not necessarily dictate giving volume to such a patient. So always remember to put your ultrasound findings in the clinical context of your patient when you're considering performing a thoracentesis. If the thoracentesis has been deemed necessary and the effusion is adequate for drainage, one must perform identification of a safe site for needle insertion. This should be done by defining the location of the maximal extent of the effusion. Then, the distance from the skin surface to the effusion must be determined so that the operator will know at which needle depth fluid will be accessed. While doing this, the operator must check for the absence of interposition of lung, heart, liver, and spleen during the respiratory cycle to avoid puncture of such organs, which can potentially lead to catastrophic complications. Also, remember that a minimal distance of 15 mm between the two pleura or between the chest wall and an underlying structure should be present to safely perform the procedure. The operator will then need to confirm the ideal entry site and ideal angle and trajectory of the needle. The angle of the needle and syringe must duplicate the angle of the transducer used to establish the safe path for needle insertion. A trajectory perpendicular to the ribcage is best. Despite not being used for real-time guidance of the needle in most cases, sonographic assistance allows determination of a safe axis of needle penetration. The procedure is thus properly designated as ultrasound-guided or ultrasound-assisted. Two other essential points to ensure the efficiency and safety of the procedure are that once an optimal and safe position for thoracentesis has been determined, the skin should be marked and disinfected, and the patient should remain in the exact same position in which the ultrasound was performed. Also, make sure you perform the procedure seconds after your assessment so as to minimize the time between the scan and the needle insertion in order to maintain a clear visual memory of the transducer angle. In some circumstances, a thoracentesis will need to be performed with real-time guidance of the needle in the pleural fluid collection. This may be the case when the collection to be drained is small, loculated, or when it's localized very near organs previously described. The real-time guidance of the needle will need to be performed following the exact same principles of ultrasound guidance that were thoroughly reviewed in the curriculum on assessment of central and peripheral vessels using either the transverse or longitudinal approach. As the needle is better seen with the linear probe, we like to use the latter to perform real-time guidance of needle in pleural fluid. The pleural effusion must first be thoroughly assessed with the phased array probe, and an optimal entry site for the needle is determined. Once this is done, we switch to the linear array probe for actual guidance of needle insertion. As the linear probe does not allow assessment at high depth, as was discussed in a previous section of this course, only the superior aspect of the effusion and nearby atelectatic lung and liver or spleen will be present in the scan field. This, however, is not a problem, as what needs to be well visualized is the fluid collection that needs to be drained and any surrounding organ in its immediate vicinity. A prior complete assessment of the effusion has to be performed with the phased array or curved linear array probe before proceeding with the ultrasound-guided thoracentesis with the linear probe. Use of the linear array probe will allow the needle insertion in the fluid collection to be well visualized during the procedure. The transverse or longitudinal view may be used depending on the operator's preference and the space available. The transverse approach is here demonstrated. When drainage is performed, we will often use small pigtail catheters that will be inserted based on the Seldinger technique. A variety of sizes and models from various companies exist. We will conclude this section by reviewing a few clinical cases.